Okay. So, good evening, all respected seniors, colleagues, and residents. I want to welcome you all on the JIAPS Abhigyan episode 6. Here we will be presenting the three articles selected by our experts. The articles will be presented by Dr. Nitin G, Dr. Pujana Kaneganti, Dr. Benjamin Cheko. And we'll like to welcome our moderators, Dr. Pinaki Debnath, professor from RML Hospital, Delhi, and Dr. Sujit Chaudhary, sir, from Apollo Hospital, Delhi. I also want to welcome Dr. Manoj Joshi, our coordinator. We'll like to welcome our Secretary General, sir, Vikesh Agarwal, sir, our President IAPS Sumitra, sir. And before that, I want to invite Rasik Shah, sir, for few words of wisdom before starting the presentation. Rasik, sir.
Yeah, thank you, Vijay. My throat is really bad and I don't want to speak much, but I am very happy that we are able to continue with this JIAPS Abhigyan. This will be episode 6. We started in March 2024, and every second month we are doing this. I request Vijay to continue with the proceedings.
Thank you, sir. Sir, I would like to then now invite our moderators, Professor Pinaki Devnath, sir, and Dr. Sujit Chaudhary, sir, to take over and invite the speakers, presenters.
Good evening, everybody. Sujit sir, can you start, sir? Hello? Hello, can you hear me?
सुजीत सर आप म्यूटेड हैं.
अच्छा, okay.
सुजीत सर म्यूटेड
Uh,
हैं.
okay. Dr. Nitin, you can start your presentation.
Dr. Nitin, you are made co-host. You can share the presentation, please.
Okay. Okay. Am I audible?
Yeah.
Yes.
Okay. And I will see my slides. Okay. So good evening, everyone. At the outset, I would like to thank JIAPS Abhigyan team and Dr. Rasiksha sir for inviting me and selecting this paper for the JIAPS Abhigyan. I'd like to thank IAPS as well. So this paper is on early esophagram and esophagoscopy evaluating anastomotic integrity in successfully treated type 3 esophageal atresia survivors. So I'm Dr. Nitin. I was senior resident in Chacha Nehru Bal Chikitsalaya, currently working as assistant professor, Kasturba Medical College, Manipal. I would like to thank my HOD, Dr. Mamta Sengar from Chacha Nehru, and other co-authors, Chabi Madam, Dr. Niaz, and Anup Mota sir. So going on with the presentation. So why did we choose this study? So what was the lacuna? So esophageal atresia, as we know, is a commonly performed surgery by the pediatric surgeons in the newborn period with high morbidity, with complications like anastomotic stricture leading to severe dysphagia, impacted foreign body, recurrent pneumonia admissions, and failure to thrive. So hence, a good postoperative follow-up was required and to detect them early to prevent these complications. And most of the studies which we see detect the anastomotic stricture after it has actually formed using various techniques like stricture index. We'll get into that. And however, so delaying this diagnosis until the symptoms appear in the infant can lead to life-threatening complications, especially in low and middle income countries like India, where they present late with the impaction of foreign body or acute life-threatening events. So hence we devised a prospective study with the aim to outcome and to evaluate the early morbidity anastomotic stricture rates, to know the instance of clinical gastroesophageal reflux and early and late complications. So the prospective study was conducted in the Department of Pediatric Surgery between July 2015 and June 2016 with all consecutive patients of tracheoesophageal fistula with esophageal atresia with a consequent follow-up of these patients for 12 months. So surgery was quite standard. All cases were open, right posterolateral thoracotomy. The anastomosis was done with the 5-OPDS, and the esophageal tracheal fistula was ligated with the 4-proline, and a trans-anastomotic feeding tube was used in all cases. So coming to definition of anastomotic stricture we used in our study, any patient showing up holdup of dye proximal to the anastomosis or significant narrowing of anastomotic site, negotiation of the smallest size flexible endoscope, 6.5 mm in our case, which was difficult classified as anastomotic stricture. Asymptomatic patients were included in the definition because of potential threat for life-threatening complications. So all patients routinely underwent barium swallow at 8 days postoperative period, second barium swallow at 2 months, the milk scan or GR scan at 2 months, and endoscopic routine follow-up for all patients at 8 to 10 weeks, 6 months, and 9 months. Routine investigations like ultrasound, QB, and echocardiogram done to rule out the associated anomalies. Coming to treatment, non-pharmacological methods like one or more feeding strategies and also positioning strategies like keeping the head end elevated were used. And pharmacological medication like proton pump inhibitors and the domperidone was advised for all patients. Coming to results, we had 64 patients presented to Pediatric Surgery Department of CNBC. 7 were excluded because they were type A or wide gap, or only gastrostomy was done. Thoracoscopic repair was excluded, and one patient died preoperatively. Out of the total remaining 57 patients, 5 left against medical advice, 2 were lost to follow. So hence, total patients in the study were 50, and we had 32 survivors. Coming to male to female, male were 66% of the patients with average birth weight of 2,390 grams. The most common associated MLI was cardiac, led to 18% of the cases. Coming to findings, leak rate was 32%, and most of the patients were minor, 87.5%. Stricture rate based on endoscopy was 11 out of 32 cases, which was 34.4%. 2 of these patients underwent a biopsy as well, and esophagitis was noted in 2 of these patients. Clinical GR and confirmed by GR scan demonstrated 80% incidence of GR, and most of them, 87%, were mild. And failure to thrive at the end of 1 year follow-up was 9%, and all these 3 patients had a severe GR. Coming to endoscopic dilation, 4 out of 11 patients would be required more than 2 dilations, and one with long gap esophageal atresia needed resection and anastomosis of the stricture after multiple failed dilation. So we can see on the left, we can see the X-rays showing holdup of dye, and then the lower images show the endoscopy being performed, and the Savary-Gillard dilators were used to dilate the strictures. So this is the video of the how we did the endoscopic dilation, and we could not. In our study there was no statistical significance noted in anastomotic stricture in the presence of GRD or higher gap length. But out of the 4 patients who required more than 2 dilations, there were 3 had high-grade reflux. Coming to respiratory morbidity, pre-endoscopy respiratory morbidity was seen in 44% of the patients, requiring to 1 or more admissions, and failure to thrive at the end of 9 months was 9%, with all 3 having high reflux. So coming to discussion versus like most of Golden et al. In their study recommended that routine early postoperative esophageal did not find any role in the predicting of anastomotic narrowing, whereas few studies which show stricture index were used in the early postoperative esophageal and found it useful and predicting the need for esophageal dilation. And Parolini et al., he said that structure index in the endoscopy done at 1 month of age correlated well with the need for anastomotic dilations. And they had a 8.6 mm endoscope, which could be negotiated if the stricture index was 0.1, and if the stricture index was more than 0.3, they could not negotiate through the anastomosis. And they had a statistically significant correlation between AS and GERD, and higher grade reflux were associated with more number of dilations. Scheuer et al. Also reported 80% of surgeons obtained a second esophagram and 12% performed esophagoscopy before 6 months of age. So contrast swallowing and esophagoscopy plays a significant role in developing esophageal stricture, but as per NASPAN and esophageal guidelines, these were done only in the symptomatic patients. And also, most of the studies done only for symptomatic patients. Second esophagram done at 38 days predicts stricture diagnosis. So Pereira et al. Also studied a second esophagram within first 60 days post-surgery with a median of 35 days and having anastomotic stricture in 67%. So what we thought is most of the strictures form at the healing phase, mainly at 3 to 6 months. Hence, we conducted these studies at 2 to 4 months of age. Hence, early screening of anastomotic stricture not only facilitates the process of anastomotic dilation, but also reduces long-term complications in these patients. And also, if we use the infant feeding tube in the OPD, we see that it is mostly did not exceed 3 mm, whereas the smallest bougie in the dilator was at least 5 mm. So to conclude, our study underscores the importance of early detection and intervention in case of anastomotic narrowing among patients operated for type 3 esophageal atresia. And these also help to pick up the cases early and dilate them if possible at the earliest stage to improve the long-term outcome in these patients. Thank you, one and all.
Thank you, Dr. Nitin, for your nice presentation. Sudhir sir, can I ask few questions and comments with your permission, sir?
सुजीत
Sir, can you hear me?
सर म्यूटेड है आप सुजीत सर.
He's muted. Please go ahead.
Okay. Yeah. Thank you for your presentation. It was all very clear and crisp. Did you have any patient where you discovered a stricture on endoscopy which you did not show up on contrast study?
Yes, there was in the paper I did mention there was one patient which was missed on the initial dye study, and then it was picked up on the endoscopy. So there was, I think I can say, only one patient.
So did you then go back and see how that case the demonstration of stricture was missed on contrast study? Was it a view problem on the X-ray? Was it done under fluoroscopy? Was inadequate contrast used? Was the baby too mobile at the time of X-ray?
At the time of these studies, most of our contrast histogram were static films. So that could be one of the reasons which we might have missed the stricture per se. And also we feel that stricture develops as a slow healing process, and then at the end of 2 months they are properly formed, 2 to 4 months where they actually form. So one had an initial normal study and later picked up on the endoscopy.
So as per your protocol, all surviving infants with TF have an esophagoscopy, right? In addition to contrast study.
Yes.
For the purpose of this study.
Yes, sir.
So there might be some questions. As far as the contrast study is concerned, there's going to be hardly any debate that a contrast study around 6 months, there will be no questions. But endoscopic intervention in a baby who's asymptomatic, I don't know whether that will go through a ethical board easily. Second issue is that we have a nearly a 34% mortality here. Is that true?
Yes, sir.
So the paper would suggest that early endoscopy is beneficial. Is that right?
Yes.
So I think you have done a very nice prospective study with the caveat that the mortality rates are very high, but I'm sure that is because of some reason which is beyond your control. Was every baby having the benefit of optimum ICU care, or were there patients who could not get ICU care because of large number of patients?
Yes. So coming to mortality, the few of the reasons which are the cause for the mortality was first one was the sepsis, which was like a major killer in almost 60% of the cases. Second reason, which we think was like those patients who presented from a far off distance while reaching the Delhi itself was late and they had preoperative pneumonias.
Yeah.
Third is sometimes there was a lack of in few cases there was lack of ventilator support where bag and mask was done. Other thing was I could say was major was the sepsis was the number one cause of death. And coming to the other question, sir, like you said, why we did a routine endoscopy for all patients. So we had few patients where they presented late, just with like at 6 months or 8 months, with just peanuts stuck in the in the upper esophageal pouch, which was very difficult to manage. And sometimes we had few cases which had sudden which is called acute sudden infected syndrome, or the acute life-threatening event. So we devised this study to in a developing country to detect these strictures very early and dilate them prophylactically, so that we don't have to face the to reduce the complication and long-term outcomes.
Were you conducting, or were the pediatric gastroenterologists conducting the flexible endoscopy in awake state or under sedation?
Yeah, we had an expert a pediatric endoscopist and who used to perform under sedations.
Right. So thank you. I think you've answered all the questions. There are lots of other
Sir, can I,
things that can be discussed, but I'll
sir, can I
invite Dr.
ask one, two
Pinaki to.
questions? Yeah.
Yeah,
Can I ask one, two questions, sir?
of course. I'm leaving it to you now to take it
Yes.
forward.
Dr. Nitin, what was the initial esophagogram? You did the esophagogram initially, I think, at the 6 or 8 days. And did you compare with the initial with the second esophagogram?
Yeah,
Because the initial esophagogram and the surgeon can predict the stricture, whether the patient will have stricture or not. The two things are constant. One is esophagogram initial and the surgeon. He knows very well which patient is going to develop stricture.
thank you for the question, sir. So initial esophagram, we detected mainly leaks and also like major or minor leak, and few patients like had narrowing, but actually the second dye study performed at 2 months, which in our study shows more pickup of esophageal stricture, and then we confirm them at endoscopy with inability to pass the 6.5 scope endoscope. So as far as data out of 11 patients, we picked around 6 cases in the first dye study where there was holdup of dye. But like I said, it was more of not like a fluoro, which we did back then. And then second one did pick up 8 to 9 cases. And then at endoscopy, all the 11 cases were picked up.
Your slide shows that the esophagogram with the barium swallow. Did you do a barium swallow in a neonate or some gastrography in something else?
Yes, sorry, it was a gastrography dye swallow.
And your esophagogram on the second esophagogram shows the 10 patients there are dye holdup. But subsequently on esophagoscopy, there was only 6 die hold up. What was the 4 cases? Was there any stricture or?
So what we thought was, as the stricture is developing as a progressive process, so over the second dye study, which is performed a little later, these were mostly more demonstrated.
No. I am asking you, the esophagogram shows 10 cases with die hold up proximal. Same patient, same 10 patient, when underwent esophagoscopy, you found only 6 had stricture. Why? What was the fate of that 4 cases who didn't show any stricture on esophagoscopy?
Uh,
Dr.
Out of
May I answer this question?
if you see data, all 11 cases had uh, the definition was based on a stricture found at endoscopy, sir. So all 11 patients had stricture and they underwent dilations.
Okay, another point from my side, the GER is out of 29, 23rd patient had GER. And you have written also, and you have spoken just now that there is no statistical significance. 3 patients had severe GER out of 23. It is around 10%. How come it is not statistically significant?
At the time of study, we did not have the confirmatory test, which is the pH monitoring, which was performed, which is conclusive study for GER. Our scan was mainly done at 2 months of age, and at that 2 months, most of the patients do have clinical GER. And other definition used for the clinical GR was the recurrent vomiting based on symptoms. So, and if we correlate that to the stricture, statistically, we did not have the correlation between the GR as well as anastomotic stricture. That's what I meant.
Because out of 23 GER patients, 3 had severe GER. And out of these 3, they had multiple episodes of dilation. That means a severe anastomotic stricture. No, so it should be statistically significant because it is around 10 to 13%. Another question from my side is your international guidelines says the multiple exposure to radiation. It's not mandatory now, but it's a controversial issue actually. I do not know this. Same with Dr. Chaudhary sir. This ethically, how much it is correct to subject a patient on recurrent radiation exposure.
Yes, coming to the first question, sir.
Even asymptomatic patient, not the symptomatic, the asymptomatic patients.
Significant complete. And in our particular center, so we did this for the study purpose, where we underwent dilation, and we did routine endoscopy for all patients of tracheoesophageal fistula survivors in type C, and we did get ethical approvals.
Sir, may I answer this question, please? Dr. Pinaki, may I answer this
Yeah.
question?
I think it is the presenter.
Pinaki, Dr. Ashish wants to make a comment.
Yeah, he can, please.
Yeah.
Thank you, Dr. Chaudhary and Pinaki. Well,
Welcome.
first of all, my best wishes and New Year wishes to everyone from the freezing United Kingdom. Maybe I'm here with all of you just to get some warmth. So thank you for inviting me. Now, Nitin, I actually enjoyed reading through your paper and certainly enjoyed listening to your paper. In spite of all the objections and of some very valid comment by Dr. Chaudhary and Pinaki that about the ethics and all the situation with it, what I can understand is that for the summary of my thoughts are that, of course, the suggestion you are making may not be valid for everybody and anybody and for all the population patient group, but maybe it was very reasonable sort of choice in the sort of patient group you are getting and the results you are getting. I can see there is quite a high leak rate and stricture and anastomotic leak rate you have mentioned, and that has led to those stricture formation. You have a population which is fast moving. If you don't pick them up early on, you might lose them and they can turn up with more problems. So maybe a protocol in such sort of a population, and the results you have. And I'm not saying that these results are due to any technical issue. That may be because of the patient population you have. I think I can see the point where you are suggesting this protocol, although I'll take it with a pinch of salt, as everybody mentioned, that do we routinely need so many radiological investigation, or can we do with a lesser number of it? That's the sort of comment I wanted to make. And I think that would summarize the overall thoughts which people will agree, rather than selling it as a protocol for which is valid for each and every institution and surgeon. Would that make sense, Nitin?
Yes. Thank you, sir. Yes. Thank you.
Ashish, don't go away.
Okay.
I think it is an excellent piece of prospectively done clinical work. While we congratulate the authors for having put in the hard work to put this piece together, there are many others who are listening to the paper and presentation. What we would want to hear from you is, should more studies be conducted with more rigor before one carries home the conclusion? Or is it scientifically robust enough to be trusted as a paper to change practice in other centers?
Putting me on spot, Sujit. I think if I answer your second question first, I don't think it is enough for other centers to change the practice. I think we need more work and maybe a multicentric trial before we make a suggestion like that as a blanket option. For a individual institution from where the study has come from, and as I again pointed out, with the type of population and the follow-up issues, the complications they are dealt with, I thought it was a reasonable suggestion, but not as a blanket suggestion. Does it? Am I getting a
Yes,
bit
I think the
politically correct
authors need
here?
to be congratulated for
Yeah.
promoting a new idea and conducting an excellent study. But just to leave it here, saying that more studies need to be done in this direction, and before drawing any definite conclusion.
I
Pinaki,
would
can we
certainly
move to the next
recommend a
paper?
multicentric randomized
Please.
trial on this, and maybe that can give an answer to us, and maybe you can have that sort of a plan within IAPS now.
We
See, the
should
trouble
congratulate
with
the authors for
is with
they
the
have put a
high
lot of
rate of
effort for this
mortality.
publication.
In the centers where the incidence of TAF is very high, those are typically also the centers where the mortality is extremely high. And when you have such significant loss of patients, then the conclusion is a little difficult to carry forward as piece of real evidence. But one of the way out is having a multi-center trial, as you suggested. Thank you, Nitin. And Dr. Pinaki, we can make a closing comment on this paper and then we move forward. Dr. Pinaki?
Sir.
Can we move forward after thanking the authors?
Yes, sir. We should congratulate them for this robust study and putting a lot of effort for this publication. We should move, sir, on the next.
Thank you, one and all.
The next presenter को invite करिए.
Hello, am I audible?
Yes, sir.
Yes.
Our next presenter is Dr. Pujana from SGPGI. Dr. Pujana, please carry on.
Yes, sir. Sir, please make me co-host.
Yes, you are already.
Yes, sir. Okay. Good evening, everyone. I am Dr. Pujna from Sangandhi Postgraduate Institute of Medical Sciences, Lucknow. I would like to share our research work on the prognostic correlation of the basic fibroblast growth factor and also vascular endothelial growth factor in the Wilms tumor and neuroblastoma. It was conducted as a prospective study. So, just a few details about these angiogenic factors. We all know that angiogenesis play an important role in the development and the metastasis of these tumors. Mainly, vascular endothelial growth factors and the fibroblast growth factors are the potent angiogenic factors, and they mainly stimulates the migration and the mitosis of the endothelial cells and also promotes the proliferation of mesenchymal cells and other endothelial cells. And also they increase the permeability of cells that stimulate the differentiation. These increased are found in the urine and blood, especially rapidly growing and the large mass. But there is a scant and variable literature in the pediatric population, and especially that compares with the radiological findings of that is the size of the solid tumors with the levels of these markers. The monitoring of these factors in the body fluids is easy to perform, especially in our clinical practice. So our aim was to determine the correlation of the serum and the urinary vascular endothelial growth factor and also the basic fibroblast growth factor with these pediatric solid tumors, that is Wilms tumor and neuroblastoma, to determine their prognostic significance. And this was conducted as a prospective study over 3 years, and after getting ethical clearance, we included the children from with the blastoma and control group of the children without any malignancies. That is, those patients who were admitted for the elective cases like hernia, hydrocele, UDT, and others. So in all these patients, that is both cases and the controls, blood and urine samples were collected at the admission, and the levels of these factors were analyzed with the ELISA method. And also contrast enhanced computer tomography was done according to the protocol in the case group. So in the case group, total of 30 patients were included, whereas in the control group, total of 45 patients were included. So as I said with the study design, at the admission, those patients with the suspicion of the solid tumor, we proceeded with the basic evaluation, that is including the hematological investigations and all the radiological evaluation. We took the venous blood samples, about 2 to 3 ml for the both factors, and also the urine samples, especially for the fibroblast growth factor. And these samples were collected before or at least 7 days after the biopsies or any invasive seizures. And these samples were sent for the assay of these angiogenic factors. So coming to the results, a total of 17 patients of the neuroblastoma were included, and whereas the Wilms tumor patients were 13. And all these patients were in the median age of 36 months with the range of 3 to 108 months. So among these Wilms tumor patients, that is total of 13 patients, 2 patients had bilateral Wilms tumor and 3 patients mets, especially in the lung, and the rest were the stage 3 patients. And whereas in the neuroblastoma patients, 2 patients were of stage 4S, whereas 4 patients had mets at different sites and rest were the stage L2. So when we had assessed the CT findings, we had found the tumor size in regards to the tumor size, that is in all the dimensions, less than 5 centimeters were found in 2 patients, about 5 to 10 centimeters was found in the 12 patients, and more than 10 centimeters in the 16 patients. So when we had assessed the values of these angiogenic factors, that is vascular endothelial growth factor and also the basic fibroblast growth factor in the both study and the control cases, we found that vascular endothelial growth factor is raised compared to the control group is 315 picograms per ml, 800 picograms per ml in the control group. Whereas basic fibroblast growth factor is about 18.9 picograms per ml in the case group. It is again as the 15.6 picograms per ml in the control group. We can see that this was significantly raised again as the control group patients. And when we had correlated with these values against each other, they were significantly raised with the p-value of 0.01. And when we had compared the urinary values in both the study and the control groups, even though they were raised in the group, there was no significant difference with the p-value of 0.1. So when we had compared with the again, when we had statistically correlated against between the study group and the control, we found that there is a statistical significance in the terms of the factor separately, that is vascular endothelial growth factor with the p-value of 0.03. And whereas in the basic fibroblast growth factor, the p-value is of 0.042, and these two values are statistically significant. This is similar to the studies done in the pediatric solid tumors by Tabon et al. And also in adult cancers, especially in the renal cell carcinoma by Edgar et al. So when we had compared these serum values again as the tumor size, they were, even though there is difference, but it is not really significant. So when we had compared these factors, raised factors with the survival, that is especially for the first 1 year after the initiation of the chemotherapy or treatment, including the surgery, even though there is a correlation, but the relation is not significant with the p-value of more than 0.05. And this follow-up period was including 6 to 40 months of the follow-up. The limitations for this study, especially the small sample size, that is only we had included only 30 patients and 2 different tumors with the different pathological behaviors. And also we had not done use of the conventional molecular markers like NMIC, and especially the short duration of follow-up period to assess the prognostic correlation. And also in sample collection, that is post-chemo samples were not collected, and also post-surgery samples were also not collected. So coming to the conclusion, raised growth factors does not show significant correlation with the radiological tumor size, but we can see that based on the results, they were raised in the patients with having the both Wilms tumor or the neuroblastoma. So we can conclude that there is a scope for the extensive research in these tumors regarding these angiogenic factors, and there is probability for the emergence of the targeting therapies. Thank you.
Well, your father seems very ready to go.
Hello.
Shall we then?
Hello. Dr. Pujana, can you hear me? Hello.
Yes, sir.
Yeah. Thank you for
Yes,
your
sir.
thank you for your nice presentations. And just a few comments from my side. You have different cohorts. Your cohorts are not properly matching because you have both metastatic as well as non-metastatic group. Okay. And you have taken Wilms tumor as well as neuroblastoma. Both in Wilms and neuroblastoma, there is normal patients as well as your metastatic patients are there. So, what do you think? Your cohorts are okay or
Yes,
need some alteration?
Sir, as I said, that itself is a limitation that we had included 2 tumors with different pathological behaviors. Yes, I do agree that we can refine in the terms of this cohort inclusion and also finance of these factors or these technical issues.
With the different cohorts with metastatic and non-metastatic different, and it would have been better study if you would have designed like this, no? Because tumor biology is different in neuroblastoma as well as in
Yes, sir. Thank you for that.
And Wilms tumor.
Yes, sir.
And one more thing, your age is from
Yes,
day 1 to 18 years. It's a long, no? Your age card is long, day 1 to 18 years.
Yes,
And
yes, sir.
I saw your paper that your controls are varied. So in that setup, you should have taken control as per age and sex match, at least, because your controls are varied.
Yes, sir. Yes.
No, so that could have been a little bit better if you should have taken it with age and sex match cohorts.
Yes, sir.
Otherwise, it's a very good study. Sujit sir.
Yes, sir. I agree with that. Yes, sir.
Yeah, I agree with your observations entirely, Pinaki. I think the study is on a slightly stronger footing than the previous study. at least there is a control group and there is a test group.
Yes, sir.
In the control group, we have variable set of patients, which is heterogeneous, although all three sets are malignant tumors. The control group could have also been slightly more homogeneous. Dr. Pujara, congratulations on completing the study. In our specialty, it is extremely difficult to do scientifically robust studies, particularly within the limited period of time that is available to a resident to complete the MCH or DNB program. So the study has limitations, but I think what you have shown is what has been known for a long time,
Yes, sir.
that these are non-specific markers with no prognostic value. However, your study proves that yet again, and scientifically it could have been better designed, but all right, there is no problem. I think it's a good study. Thank you for your presentation. And Dr. Pinaki, if we can invite any comment from the audience, if there are
Yes, sir.
like any comments.
Yeah. Anyone from audience? No comments? No comments from audience, sir.
Then let's move to the next paper.
Yeah. Congratulations, Dr.
Thank you,
Pujara
Dr.
and the
Pujara.
whole team in the SCPGI for this nice study. Thanks a lot.
Sir. Sir, I thank especially our HOD Sir Vasant Kumar Sir for giving me this opportunity, and also all the seniors and dignitaries of the JIAPS Abhigyan committee for giving me this opportunity to present our study. Thank you, sir.
Can we invite our next speaker, Dr. Chaco? Dr. Benjamin Chaco.
Hello. Yes, sir. Good evening.
Good evening. You can start, please.
Yes. Good evening, everyone. My name is Dr. Benjamin Chapo, and greetings from Narayana. Today, we will be presenting a paper titled Prospective Study of Impact of Preoperative Nutrition on Postoperative Outcomes in Pediatric Surgery using Novel Two-Axis Classification Scheme. This was published in the latest edition of the JIPS. Now, over time, the definition of malnutrition has evolved to include not only deficiencies, but also excess of nutrients that can negatively impact the growth and development of patients. In the current Indian scenario, 35% of our children are stunted, nearly 20% are wasted. And on the other end of the spectrum, 3.5% of our children suffer from overweight and obesity. As per the current WHO understanding, the relative risk of death in patients with severe malnutrition is nearly 6.8 times. But unfortunately, all of this is adult data, including the data correlating the preoperative nutritional status and post-op complications. There is a great severe lacunae in the pediatric data on such conditions. Even in the latest review articles by Wessner et al., most of the studies are retrospective, and the remaining are prospective studies are limited by the type of surgery and type of cohort that was taken. The largest study taken so far is one done by Anastasia et al. In 2019, which was the first study to use this two-axis novel scheme, but even theirs was a retrospective study. This is primarily because the nutritional assessment techniques in pediatric age group is not standardized. There are no international standards, and the tools can range from simple objective measures such as anthropometry to biochemical markers to long subjective questionnaires. And to address this issue, we at Narayana aim to study the effect of preoperative nutritional status on the clinical outcomes. with a primary objective to determine if preoperative nutritional status affected the 30-day postoperative outcomes, and secondary objectives including to identify the prevalence of malnutrition and identify any specific nutritional profile groups that were at risk for postoperative complications. This was a prospective observational study conducted between Jan of 2021 to April 2023, and the calculated required sample size was 956. We included patients more than 28 days of life and under 18 years of age. Only those patients who were admitted to the ICU for other major illnesses were excluded. All patients were recruited at the time of surgery into the study. The socioeconomic, demographic, primary disease, and comorbidities were noted down, and the preoperative anthropometry, which included height and weight, were measured by the standard WHO guidelines. The BMI was calculated from this. Now, we used height as a surrogate for long-term or chronic nutritional status, and BMI as a surrogate marker for acute nutrition as well as proportional growth of patients. And using the WHO and IAP growth charts, we calculated the Z scores for both BMI and height. A Z score of less than -2 or greater than +2 were considered abnormal. And for a patient to be classified as malnourished, we required both them to have an abnormal BMI as well as an abnormal height. Based on this, we divided the patients into 4 categories: underweight short, underweight tall, overweight short, and overweight tall. Those patients who did not belong to any of these categories were considered to be normal and non-outliers. All patients were followed up until post-op day 30, and all complications were noted down. And for simplicity, we classified the complications into composite, healthcare-associated infections, re-intervention events, and mortality. These were further graded using the Clavin-Dindo score, and all the postoperative morbidities were then analyzed against the 5 nutritional profiles, and odds ratio were calculated for each group, and a p-value of less than 0.05 was considered statistically significant. As we recruited 827 individuals who underwent 1,022 surgeries. Now, those individuals who underwent multiple surgeries were considered as a new unit or new subject at each surgery because of the change in the anthropometry. We did not have any attrition in our study. This was a male predominant cohort. Nearly 70% of our patients were boys. The most common age group was between 5 to 7 years, accounting for 33% of our group. Now, as per the traditional nutritional profiling, about 30% of our patients were malnourished for weight, height, and BMI. But based upon the 2-axis scheme, only 10.4% of our patients were malnourished, with the largest group being the underweight short and the smallest being the overweight tall. We had 140 complications in 103 patients during the study, and there were 3 mortalities. All the 3 mortalities were due to postoperative sepsis, and in those patients who were normal nutritional status. Now, when we looked at the different nutritional profiles versus the different complication categories, we noted that only the underweight short group had higher incidence of complications compared to other malnourished children as well as the overall group. And this incidence was nearly 2 to 3 times the groups. When we looked at the overall malnourished group patients versus those who had normal nutritional status, even though there were higher odds of complications in the malnourished patients, this was not statistically significant. But when we looked only at the underweight short cohort, they were found to have higher incidence of composite morbidity, healthcare-associated infections, and 30-day overall morbidity. And this was statistically significant with an odds ratio of more than 2. On comparison of all the nutritional profiles, only the underweight short patients had higher incidence and higher odds of complications. But even under the underweight short patients, they only had increased risk of surgical site infection and sepsis. There were no increased risk for other complications. But the severity of complications had the nutritional status did not have any bearing on the severity of complications. Unfortunately, due to the low complication rate, despite having more than the required sample size, we could not do subgroup analysis of major minor surgeries, comorbidities, and other third factors. Now, the complication rates in our study were comparable to others, those done by Anastasia et al. There were fewer trauma cases and more tertiary care, multidisciplinary treatment, hence we had lesser mortality. The most common surgical complication was a surgical site infection, which was similar, 4.8%, which was similar to the other studies. Now, comparing to the first study, which used the two-axis scheme, that is a Anastasia et al. Study, we had the similar findings that the outliers of the malnourished patients did have higher odds of complications, but that was not statistically significant, and only the underweight short group had higher incidence. This study underscores the need for a tailored nutritional profiling group for surgical cohort. And based on this scheme, we were able to identify that only the underweight short patients were at risk of postoperative complication due to nutritional complications. To conclude, two-axis classification scheme is feasible technique to classify the pediatric surgical cohort into anthropometric nutritional profiles. The prevalence in our cohort was of malnutrition was 10.4%, and only the underweight short patients were at risk for postoperative composite morbidity and healthcare associated infections. The strengths of my study were that this was a prospective study with objective parameters and included all patients, including all surgeries, and hence it was better reliability and applicability. This was a single center study with same management protocol for all complications, and we had a larger than required sample size, and there were no attrition in our study. The only limitation was that this was done in a tertiary care center, hence the socioeconomic population would differ from other centers, and we could not analyze the confounding factors and comorbidities due to the rarity of complications. Thank you.
Thank you, Dr. Benjamin, for your nice presentation. And a few comments. One is your cohort. In your cohort, the age range is again on 29 days to 18 years.
Yes, sir.
So how will you compare? This is only one is neonate, another one is adult, 18 years.
Yes, sir.
So do you think it's a proper study design?
Sir, the advantage of this was that we were not using the weight and height in itself. We used a Z-score based upon the growth charts that are there. So we can compare these and say that this Z-score is less for this child. So it is comparable in that sense. This is as close as to any comparison that we can have for that fact. Unlike the lab parameters or other parameters or nutritional profiles that are available elsewhere. So it is comparable.
And your major complication is SSI. So SSI depends on so many factors. There are some patient factors, there are surgical risk factors. Okay. So,
yes, sir. Yes.
So how will you compare here? Okay, SSI, not only nutrition, there are lots of points there for the SSI. Yes. You cannot blame the nutrition alone.
Yes, sir. Our idea was not to point that it is the only cause for the SSI. We did take all patients. So we had patients who had all diseases, all comorbidities. So it was as homogeneous as a cohort can be in terms of taking the entire population. We took the entire age range. So those were the factors that played to our benefit. We did take into account comorbid conditions and other, whether they receive chemotherapy and things like that. But unfortunately, because of the low rate, we were not able to analyze that data because there weren't enough complication rates in each group to compare to. So that tables we have submitted in the article, but as it is low numbers, so it is difficult to compare and analyze them because each one of the groups will have a zero complication rate. It becomes difficult. So a larger number, yes, we can.
Lots of confounding factors are there in your paper, like surgeon's bias, the type of surgery you are doing, and how will you comment on that?
Sir, this was done. We are a single unit, so all the surgeries were done by the same technique, not by the same surgeon, but by the same technique. The post-op management, the pre-op assessment, post-op management is all done by us. So it is the same protocol. It was not changed for patient to patient. So that is one way. And yes, sir. So as far as that is what we kept constant throughout the study.
What is the scientific basis that our short stature underweight is having more complications?
The point of using two of these factors is that in pediatric patients, we face children who have larger comorbidities, complications, syndromic patients. So their growths are affected by these comorbid conditions. Now, when we look at we expect them to be abnormal for both acute and chronic, because in children, the nutrition provides to both growth of the child for development as well as maintaining homeostasis, unlike in adults where it is only homeostasis. So that is why we have divided taking acute malnutrition and chronic nutrition together, hence dividing them into underweight, short. That means underweight, so they were acute nutrition defects were also there, and they were short, so chronic malnutrition also was there. So they were bad in both acute as well as long-term nutrition status. Hence, they had more complications. So because lot of surgeries that we do, we often postpone the surgeries because they are not, they are malnourished. But what is malnutrition is what we wanted to define. We are not suggesting that it is the only factor for the complications, but what is the correctable factor and what should be the malnutrition group that we should be targeting therapy towards is what was the target of our study.
Do you think the study design is optimum or could have been better?
Sir, the ideal would have been to do a multi-centric study to include all different backgrounds and socioeconomic statuses. But this was more like a pilot study to kick that off. So yes, we would have preferred to have much larger numbers. That would have made the study better. So we could have done a multivariate analysis and taken into account and done the analysis of the comorbid conditions and other factors that we did take.
No. Sujit sir.
I think, thank you, Benjamin, for a very nice presentation. Is there any doubt in the correlationship between growth failure, malnutrition, and surgical morbidity?
Sir, majority of our understanding on this subject is based from the adult data. So we extrapolate them to pediatric. But one of the things that we don't take is that pediatric growth the patient is actually growing over time, unlike in adults where it's pretty much constant. Their height is not going to
No,
grow.
your study is very important. Your study is very important, and I just wanted you to spell it out. Your study has brought out that clearly growth failure and malnutrition are not necessarily correlated. For example, a baby with PUV may be having serious growth failure because of being in untreated acidosis, whereas may not be malnourished. So your paper has brought out that although it could be much better controlled study, it's not that well controlled, but it has brought out an important fact that if you have a short or a child with growth failure and malnourishment, he is at risk from serious surgical complications. Is that what you have concluded?
Yes, sir. Yes.
Thank you for your presentation. I loved listening to you. Thank you for the hard work.
Thank you so much. Thank you.
Dr. Pinaki, any comment from the audience you'd like to invite?
Hello. Yeah.
There's one question in the chat box.
Anyone from audience? Any questions?
There's one question in the chat box. Dr. Pinaki, if you can take that.
Okay, I'll see. Chat box.
By Dr. Ankur.
Dr. Ankur.
So can I read that? Does the primary diagnosis which itself causes malnutrition, for example, small bowel or esophageal stricture, etc., affect the results?
So any patient who has the primary, the point of doing the before the surgery to check nutritional status is to optimize it if it is low. So even if irrespective of what disease it is, we will do a nutrition therapy before we take a patient to surgery. We will do the nutritional assessment. So even though we have taken that into account, it does not affect the fact that if a patient you need to take them, you need to have normal nutritional patient. You can't put them at risk unless it's an emergency.
Can I ask one question?
Yeah, sure.
Yeah, thank you. Although I have asked multiple questions to Benjamin while reviewing this paper, so I have no right now. I assessed it as UC Chakravarti award paper also. But one point I think it should have come in the presentation as a limitation that the type of operation you chose were emergency as well as non-emergency operation, and the contaminated as well as the clean, contaminated or clean operations, because they may be the did mention about confounding variables, but these were the like apart from comorbidities, these were also confounding variables.
Yes, sir. Yes, we,
Yeah.
as I said, we took an entire range into that.
You can elaborate on
The
your
small
limitation
numbers
slide.
were difficult to.
No, it's not criticizing the study.
Yes, sir.
It's
Definitely, I will do that.
PowerPoint. You can like expand your limitation slide a little bit more. So these more questions won't arise in the discussion next time.
Yes, sir. Yes.
If you
Sure,
present
sir.
it somewhere
Thank you so
else.
much.
Okay. Thank you.
Thank you.
Okay, no more question then. Thanks, Dr. Benjamin, for your nice presentation and robust study, and congratulations to your senior too for this study. Okay. Now over to Dr. Vijay.
Manoj sir, please.
Yeah. So as we come to the conclusion of this sixth episode of JIAPS Abhigyan, on behalf of the editorial team, would like to thank you all. Thank you, our esteemed moderators, Dr. Sujit Chaudhary sir and Dr. Pinaki, for sparing your valuable time and eliciting very thoughtful discussions. I would like to also thank our presenters and the authors of the manuscripts for taking us into the in-depth of the articles. And would also like to thank our Honorable IAPS President for logging in and giving valuable insights, and Secretary General Dr. Vikesh Agarwal also for providing valuable insights and offline support. And apart from that, our participants, around 70, have logged in this time. So thank you to all of you for raising your questions in the chat box and participating in the discussion. Thank you very much. Thank you to all. Dr. Asik Shah, sir, should we conclude?
Yeah, we can conclude and request to President, Secretary and moderators to continue on Zoom. Others can leave. You can conclude.
Thank you, sir. Thank you very much.